Today, we've got some interesting bills on the calendar, and we're going to dive right into it following the agenda that we have. So the first bill we have on the agenda is House Bill 1104, Improve IVC Process and Enhance Public Safety. There is a PCS for this bill, and Senator Daniel moves that the PCS be brought before us. Any objection? No objections. The PCS is before us. And the chair will recognize, to begin with, Representative Reeder, who we welcome here to the Judiciary Committee. Thank you, Doc, for being here.
Thank you very much. I'm from Pitt County, and my sponsor is Senator Britt, and I'm happy to be here today.
I don't think that's a very good sponsor. We'll roll on. We'll roll on.
It's been 6 months since my last confession, so. Thank you.
You recognize Representative Reeder.
Thank you, Mr. Chair, members of the committee. Thanks for allowing me to bring forth House Bill 1104. This is the work of the House Select Committee on Involuntary Commitment and Public Safety that the House has been working on for a number of months, held a number of hearings to work on the issue of people who have criminal behavior and also have mental illness. And that's the output of the work. And I want to thank Representative Blackwell and other members of our committee who've been working on this for a while. We have met with a number of stakeholders from the Sheriff's Association, HHS, Administrative Office of the Courts, Conference of the DAs, the Healthcare Association, and the Collaboratory to get to the product that you see in front of you. This bill has a number of sections, and I suspect that in the Senate you don't want me to go through every one of them, so I won't. I'll be happy to answer questions. But the main points of the bill are to allow and make sure that people who have criminal behavior get an evaluation to ensure that if they need treatment for mental health, that actually occurs. We know that there's been too many cases like Irina Zarutska where there was someone who had criminal behavior, mental illness that was not adequately identified and treated that caused injury to our citizens. And that's what this bill helps to do. It drives the evaluations for this to the jails. Using telehealth is the goal for this so that we are protecting public safety while ensuring that the evaluation is done. I know that you have a PCS that we've been working, and I want to appreciate Senator Britt and Senator Story who've been working on this with us in the House for weeks to try to get this product correct. And so, again, I'm happy to answer any questions that folks have.
Thank you, Representative Reeder. I believe there is an amendment, but would you like for staff to go over any parts of the PCS before we turn to that amendment? Okay. All right. The chair recognizes Senator Britt, who I believe has an amendment.
Members, you should have the amendment in front of you on your desk. Do you have the title of the amendment book? I don't have it in front of me. Is that 1104 ACE 141 version 3? That is correct. The majority of what the amendment does is, yeah, that's the correct one. The majority of what it does is technical in nature, pushes out some dates. We've worked on all the changes in the amendment with all the stakeholders, Department of Health and Human Services, Sheriff's Association, as well as the Healthcare Association. So all the changes that are in the amendment have been vetted through those groups. There's also some changes to 15A. Those are the only substantive changes, 15A 1000 to 1007, which deals with incapacity to proceed in the process for what happens once someone is found to be incapable to proceed in a criminal matter. That's something we've actually worked on for the last probably 2 years with the Conference of DAs and Department of Health and Human Services, and kind of finally have that in a spot where we can put it into law. Ask for your support of the amendment and can explain any part of the amendment if necessary, or can direct to staff.
Thank you, Senator Britt. Questions or comments from the committee on the amendment? Senator Grafstein, you're recognized.
Thank you, Mr. Chair, and I appreciate the amendment sponsor. Just a couple of questions, if that's okay.
Ask your question. Let's roll.
Yes, sir. Senator Britt, I'm trying to read through the amendment as quickly as I can. There's a change in one section on page 4 that changes information, it changes a referral for IVC in the capacity assessment process, that someone may be referred for IVC, and that's been struck through. And I'm just curious, in terms of the changes in the structure of the process, where would IVC come back into the process for somebody is going through the incapacity to proceed proceedings?
Senator Britt, you recognize.
That would come into play after a hearing before a judge.
Follow up.
Follow-up, thank you. Hearing on the capacity to proceed?
Correct.
Okay, and then there'd be a subsequent IVC determination?
Correct.
Okay. Thank you.
Thank you, Senator Grafstein. Other comments or questions from the committee? Senator Representative Reeder, do you wish to address the amendment?
No, I was trying to scan a little bit, but we've been working together, and I trust that Senator Britt's gotten everything correct without any questions.
That's a lot of trust. I'm not sure even in the Senate we go that
Mr. Chairman,
Senator Britt, you're recognized.
I would like to later ask that those words be spread across the journal.
I'm certain we can arrange it. All right. All those in favor of Senator Muhammad, you're recognized.
Question for Senator Britt.
You're recognized for a question.
In your amendment, does it have the language defining what relevant past is when it's talking about first examination for outpatient?
Senator Britt?
That is not in the amendment, but staff can probably explain where that's in the bill.
Okay. How that's defined?
So, Rob or Hannah, would one of you guys be able to address that?
Yes, sir. That is not in the amendment. That in the PCS, I think what Senator Muhammad's referring to is on page 7, line 3, and the PCS does not define specifically what relevant past is, sir.
Okay. If I could ask.
Follow up?
Yes. So, Representative Reeder, I was looking at that criteria as far as the first evaluation for outpatient treatment. It just says relevant past is what should be taken into consideration. So are you thinking about defining that further? Maybe, I don't know, 5 years, 10 years?
Representative Reeder?
Specifically?
If I remember, I think that you're talking about in the section on assisted outpatient treatment, if I remember correctly. In that section, we define elements that may require an inpatient evaluation or another evaluation, and we don't define relevant past. There's a number of situations in there. If you're arrested again, if you have another inpatient commitment, above that, it will say that the evaluator may consider all of these things. So we have not, to answer your specific questions, we did not define relevant past. We assumed that the evaluator would take all of that into consideration in totality. And so that's why we chose not to define that relevant past.
All right, Representative Muhammad, is your next question on this same area?
Same.
Okay, will you please hold it? I'll recognize you next.
Sure.
Are there any other questions on the amendment that's before us? Seeing no further questions on the amendment, all those in favor of the amendment, please indicate by saying aye. Any opposed? The ayes have it. The bill is amended. It's back before us. Representative Muhammad, you're recognized for your next question.
Thank you, Senator Newton. So, Representative Reeder, real quick. So, I understand what you're saying, the different criteria that's taken into consideration. Only for due process sake, I would suggest you potentially try to provide some sort of span, maybe 10 years. People can change. I don't know. I don't know how far somebody relevantly needs to. We need to go back 10 years, 30 years. So, I mean, just for due process sake, I would recommend that. And otherwise, I do have other questions about the bill, Senator Newton.
Okay. Are there other questions? We'll get to give everybody opportunity. Other questions on the Senator Gailey? I'll come back to you, Senator Muhammad.
Thank you, Mr. Chairman. Representative Reeder, I just have really a basic question. Is your bill, is it the intention of your bill just to really look at the IV process for people who have somehow encountered the criminal justice system? I guess people who maybe have been arrested and are awaiting some kind of processing, because IVC can encompass a lot of different situations and different individuals. Can you just reflect a little bit for us on the genesis of the bill and what is the problem that you started out seeking to address?
Thank you, Senator Gailey. Representative?
So thanks for your question. There was a lot of tension in our committee. In the genesis of this, when we passed Arena's law, we recognized that there is an issue of people who are in jails, who are in prison, who have serious mental illness. And it wasn't clear that they were identified and or treated. And there's an overlap of people in that. Most people with mental illness do not commit crimes and do not commit violent crimes. And many people who commit violent crimes don't have mental illness. But we know that there's some overlap. What we were trying to do in Arena's law and then subsequent is to look at the intersection of those populations, people who have criminal charges or criminal activity, but also have mental illness. In our committee, there was tension of how much of the mental health system are we trying to fix? And we've taken 20 years to get to the broken system that we have. So our committee was really focused on this subset of population. We know and we learned in our hearings that there's some things that are in the bill that will help patients who have mental illness that don't have criminal behavior. The whole idea of outpatient assisted treatment or outpatient IVC, there's a section in there that will be equally applicable to people with criminal behavior and not. But really a lot of the work is focused on those people with criminal behavior. And really it's about getting that first evaluation. What we believe, what we heard from a lot of testimony from all sorts of groups and individuals is that one of the challenges is that people who have criminal behavior and have mental illness never get evaluated fully. And they linger in our jails and in our mental institutions, in our prisons, because they're not getting treated. And so if we can get that evaluation, get a diagnosis, get them on treatment, that may and hopefully will mitigate the safety for the rest of the citizens, but also for that individual, get them better treatment.
All right. Thank you, Representative. Any follow-up, Senator? Okay. Senator Senator Britt first, and then I'll come back to you, Senator Mohammed.
At the appropriate time, move for favorable.
Okay. All right. We have a motion. Senator Overcash, you are recognized.
Thank you, Mr. Chairman. I have to take advantage of not only having a legislator here, but a physician. Thank you, Dr. Reeder. My question's a little more general. How is telehealth assisting us in this process and technological advances from, say, 10, 15 years ago? Can you talk to this committee a bit about that?
Great question, and that's where. Great question, and that's
Representative Reeder, you are recognized. Go ahead.
Sorry. Great question. That was one of the things that we know in emergency departments today. Many patients who don't have criminal behavior are evaluated via telehealth. There are companies, agencies, and that's how a lot of that work is done currently in emergency departments. Psychiatry is one of those things that you don't actually need to touch the patient as much. That technology can be used in the jails for this evaluation. It prevents sheriffs from taking them, someone who might be accused or arrested for violent behavior, taking them into the general population of an emergency department. You wouldn't want someone who had just committed a violent crime sitting next to your child when they're getting treated for an ear infection. And so we thought that technology could be used in the security of a jail to have that evaluation done. Those evaluations done now, and we believe that this technology exists. The other thing that's in the bill is if for some reason that's not adequate, the patient's paranoid of the computer, there's things called mobile crisis where an individual could come to the jail to perform that evaluation. Mobile crisis units are in every county in the state right now. They're not doing this kind of work, but it's not a large stretch to say this couldn't be augmented to be able to do some of these evaluations.
Thank you, sir. Let me get Senator Mohammed, and then I'll come to Senator Lazar. Senator Mohammed.
Thank you, Senator Newton. Representative Reeder, again, thank you so much for this bill. I think it's critically needed. I appreciate your efforts and many of the folks who've worked on your committee and worked with you alongside. Question for you. My concern always with studies is that sometimes we study it and then we're not going to actually fix it. So specifically related to the working group to address the revolving door, which is a critical issue, why not just create some sort of intensive case management program for those individuals? That's one. Especially with the individuals with repeated IVC petitions, in and out of jail. You know they're in crisis, so why not just get them the direct help that they need? So sadly, what happened to the young lady doesn't happen. And the other thing is the mobile crisis units. I mean, we already know they work, so why not try to expand those, fund it and expand it so they can also have first evaluations. instead of studying.
Thank you. Representative Reeder, I'll let you take a stab at both of those real quick, and then I want to move to Senator Lazar. We do have some other bills, so we want to keep moving along. Thank you.
So the mobile crises are up and running. We have funded those. Last year, a lot of money went into mental health. Currently, most of those mobile units are not, in my opinion, equipped to deal with these more complicated patients. The evaluators, the mobile crisis are accustomed, and they do this every day, evaluating someone with schizophrenia or depression for anxiety. When someone has criminal charges attached to them, in my opinion, and what we heard from some of our people that do this, it changes that dynamic a little bit. And so it's a more complicated clinical question. So there's a section in there about additional training from the Department of Health and Human Services for those mobile crises if they're going to do that. Okay? So I think that's how I would address the mobile crisis. Your first question was about studying. What we heard from a lot of different people was we've identified issues. We know that there's problems. There's varying levels of solutions that are apparent. And so what we were hoping to do, and I get we're pushing this off a little bit to study it because we didn't have clear answers on a number of these things. And so that's why we have a lot of studies in there. The one piece that we did hear pretty clear was the outpatient assisted treatment, that outpatient involuntary commitment. That is something that North Carolina led on many, many years ago when we had mental health reform in North Carolina and the LMEs came into being. We lost that. And so that's one thing that we heard very clearly that we need to get up and running. And so that is baked into it, or say, let's move forward on that.
All right. Thank you, sir. Senator Lazar, you're recognized. And I'll come to you.
Thank you, Mr. Chairman. Thank you, Dr. Reeder. Can you talk a little bit about, I know that a lot of these folks get evaluated at the various stages, and a lot of them suffer from mental illness or substance abuse or connected both ways. And while they're under care, they're prescribed medication that they need. But when they're removed from care, they cannot continue their medication that they're prescribed. I think that is one of the bigger issue in the community, because while they're under care, they're getting, whether it's antidepressant medication or anxiety medication or substance abuse antagonists. But when they leave, even with outpatient, they're not able to fill their prescriptions. And I hope that this would be somewhat part of the study because if they can't continue their medication, they can't continue their wellness process.
Representative?
Agreed. And what we see is that many patients, when they get well on their outpatient regimen, they're great. Some people need hospitalization sometimes for a long time. What we talked and we heard a lot about in our committee was this assisted outpatient treatment. So outpatient involuntary commitment, someone who would be in the community, but as part of their treatment regimen, they might have to show up at their physician. They might have to take their medication, and there's some teeth in that if they fail to do that. And that's where we get back to Senator Mohammed's issue, is if they're not doing that, that might be grounds to then involuntarily commit them to the hospital for more intensive treatment. And that's where we in North Carolina are not doing a very good job right now, and that's the intent of that section, is to get something between hospitalization and outpatient treatment.
Thank you, Representative. Senator Grafstein.
Thank you, Mr. Chair. And Representative Reeder, thank you. I know that there's a lot of work that has gone and will go into this issue, and it's something that a lot of people care a lot about, and I appreciate all your work. It is a big topic that has to be dealt with carefully, I think. And so my question really is about one specific part of the study. It's Section 5A. It's the study about staffing and bed shortages in state-operated facilities. I think a lot of really good focus and work on the issue about staffing issues and so on. One of the pieces I didn't see in here, and I hope would be considered, and I don't know if for incorporation in the bill or just by the study, there are, I guess, on any given day, about 20% of the beds in state-operated psychiatric hospitals are filled by people who are ready for discharge, but there's nowhere. There aren't community-based services available for them to go to. And, you mentioned the LME earlier and the kind of the role that they play. That array of community-based services really is the responsibility of the tailored plans and folks we are paying to make sure that those services are available. And so it's sort of a question. I guess I would ask if you agree or if you would consider this, but looking at the question of why those beds are occupied, because that's a fairly substantial piece of an already shrunk pool of beds available that are not out of use because of staffing issues, but are in use because people could be elsewhere, and we could be spending less money, frankly, and they could be getting better treatment in the sense that they would be integrated back into their communities if that issue was addressed.
Representative? And I would ask y'all, let's speed this up. We got 2 other bills we got to get to.
Got to get to the skiing bill.
We've had a great relationship with the department. I know Dr. Carrie Brown has now been tasked to lead the efforts in the state facilities, and she has come up with a great plan to help staff more beds to do a lot of that work. So I have great faith that we are on a different trajectory than we have had before.
Thanks, sir.
One
You have a
follow-up.
follow-up quickly?
Yeah, just last follow-up. I appreciate that, and I think the other piece, and that's the piece that I think is amply reflected here. I would just ask that we are also looking at those beds and the capacity in the community for folks who really have gotten the great care that they're going to get at the state operative facility and are ready for discharge.
Thank you, Senator. All right, with that, is there anybody from the public that signed up to speak on this bill? We do have a motion before us. I'm not seeing anybody move to the podium. I don't have a list in front of me, so we do have a motion from Senator Britt. He moves to amend, he moves for a favorable report to the PCS as amended, rolled into a new PCS, and unfavorable to the original bill with a referral to rules. All those in favor, please say aye. Any opposed? The ayes have it. Thank you, Representative.
Thank you very much.
Appreciate you being here. We look forward to your next visit. Moving on down our agenda, we have H565, limit use of AI Medicaid commercial insurance bill, and Senator Galey is going to present the bill, and I know that there is an amendment. Would you like for us to adopt the amendment first or deal with the amendment first, Senator?
Mr. Chairman, if I may make sort of a short introductory
You're recognized.
remarks for the topic and then do the amendment. So we're in Judiciary, not in Health, but I wanted to give a brief overview of why is this bill needed? What is the problem that this bill is seeking to address? There is an indication based on billing developments in the last 3-4 years that that some providers in the country are using billing systems that are designed to increase the billing. One of them is Abridge, is a company that on its own website discusses how Riverside Hospital in Virginia, when they started using Abridge, they saw an 11% increase in their billing. The issue is that the code itself appears to have a bias written into it which enhances or elevates the charge. So hospital billing is done based on 2 things. One, the actual service provided. So if you get a transfusion or you have an operation, the fees for that service. And then also there's charges based on the severity of the condition that the patient's being treated for. So an infection versus sepsis. And there is an indication from the billing, I'm told, by some of the health insurance companies across the country, that while the treatment for certain conditions has remained the same, the billing for it, or the acuity of that, has dramatically increased, in some cases by 19% in 1 year for some conditions. So this bill is an attempt to get at the root of the problem. The root of the problem is not the practitioner. The root of the problem is not the person who is doing the backside of the coding. The issue is the algorithm itself. And has it been written in such a way to enhance the billing? I'm told that if I go to get my DNA looked at for the BRCA gene for breast cancer, for example, somebody who is qualified to do DNA analysis can unroll my double helix and look in there and see, do I have that gene? Similarly, somebody who is qualified in computer coding to that degree can look at the code that is written that the hospital systems may be using to see, does it have that bias in there? Is this a billing system which is designed to generate a maximum payout? There's an issue with phantom objectivity. It will look like it's an objective rendering of a patient encounter, but the system itself is rigged to generate the highest cost. And the bias itself is baked into the algorithm. We do not want to stifle any kind of efficiencies that can come in healthcare from adopting artificial intelligence. We want to encourage doctors to use the ambient listening system to decrease their having to do the physical charting, which has taken them hours and hours and hours to do. We want our healthcare providers to be able to use AI tools for better diagnosis and for better treatment of the patient's condition. But we do not want to unleash a inflationary element into our already tightly constrained healthcare system with people who are severely burdened in our state and our country by overarching costs across our economy, but especially in healthcare. We know that North Carolina has exceptionally high healthcare costs compared to the rest of the country, and this bill is a proactive approach to dealing with those rising costs in the future. So, Mr. Chairman, we're in Judiciary, and I believe that the amendment is relevant to Judiciary because, well, I don't know if the amendment sponsor wants to.
Yeah, we'll take that up here. Thank you, Senator Galey. The chair recognizes Senator Daniel for an amendment.
Thank you, Mr. Chair. This amendment is H565 ABC 82 version 2. This amendment just clarifies that the Chapter 75 unfair and deceptive trade practices portion of the bill may only be brought by the Attorney General. Ask for your support.
All right. Thank you, Senator Daniel. Questions on the amendment or comments on the amendment from the committee? Senator Galey, do you wish to address the? Let me ask Senator Galey first. Do you have a question or comment on the amendment?
I do not. It's a friendly amendment.
Senator Blue, you're recognized.
Thank you, Mr. Chairman. Senator Daniel, just so that I'm clear on this, this does not affect KETAM actions. You're just authorizing the AG to be the one taking the lead. But when you say only he can bring an action under this particular statute, are you attempting to limit those private actions?
That's a good question, Senator Blue. Thank you.
So restate the first part.
KETAM.
Restate the first part of your question.
Yeah, under current law, this concept of KETAM actions, citizens' actions brought.
Hang on just a second.
So are you saying, like, could a Chapter 75 action be brought anyway, just not using this subsection, I think?
No, by individuals, yeah. By individuals, if there's a feeling on their part that the Attorney General has not aggressively pursued an area, then there are provisions that individuals can bring those actions, and the Attorney General at any time can intervene in them and take charge of them. But they're initiated by individuals who identify an area that is prohibited, but the ultimate authority, that is the Attorney General's office, is not pursuing them. That's a concept at the state and the federal level. And I'm wondering if it's not the goal to specifically limit those, does the way that it's written limit those KETAM actions?
Thank you, Senator Blue. Do you wish
That may be a question for staff ultimately, but I think, since this is, all of this language is contained in the new subsection that falls under Chapter 75, so I think the intent of it is just not to create a new sort of automatic Chapter 75 right of action that could be utilized by private parties.
Okay.
Thanks, Senator Blue and Senator Daniel. Jason, can you address that about the KETAM actions and whether that would be affected by this amendment?
Yes, Jason Moran Bates, Legislative Analysis. So the amendment just says that under Chapter 75, there are two ways to enforce that. There's the Attorney General action and a private right of action. The amendment just says that bringing an action under Chapter 75, only the Attorney General can bring that action. If you look at the bill as it currently stands, On page 2, lines 30 and 31, it says, nothing in this article shall foreclose other remedies available under law or equity. That language isn't being changed at all. So the amendment is just applying to unfair and deceptive trade practice actions brought under Chapter 75.
Thank you, Jason. Thank you. And appreciate, Senator Blue, your question. You always ask good questions on this committee, and we appreciate your input. You have a follow-up question?
No, I do have a question for Senator Gailey.
You may ask your question, sir. You're recognized.
Yeah, I was trying to follow the logic here that there's a bias in the algorithm for this billing process. I can see that where you're talking about direct action by parties involved, but where you got third-party payers, why would the insurance companies not have some system to correct that bias?
Senator Gailey?
That's a great question, Senator Blue, and it really gets to the heart of the need for this bill. The insurance company definitely has opportunities on an individual claim-by-claim basis to challenge a claim, and they do it, I'm told, all the time, and very vigorously. But this is a proactive approach, and it's bigger. This is bigger than one individual case. This is bigger than one individual patient. This is about a sort of a gut punch to the entire billing system. An individual, if I got a bill for, I don't know, a colonoscopy, and it looked, I don't know why my colonoscopy is so expensive. I don't really have the access to data or information to compare that relative to other patients and their experiences and what they've been charged. An insurance company is in a unique perspective because they have access to thousands of claims across the entire state or even other states. And so they can identify outliers. They can identify that, oh, we have with postpartum anemia, we have an incredible escalation in the diagnosis of that, but the number of people who have been getting transfusions has stayed exactly the same. Well, that's an anomaly that started at a particular point, say in 2021, where they also saw other anomalies, like, oh, this one hospital, they've started charging for sepsis, and they've had a huge escalation in sepsis while the exact same treatment's been going on. So an insurance company would have access to the data to say, this is something we need to look at. There's something fishy going on here that is not, it's not one person sitting, a coder who's been well-trained, a human being who's been well-trained in coding. This is something that looks like is baked into the system itself. And so this bill would give the insurance company ability through the Attorney General's office to crack that code to say, let me look at it, just like they can look at my DNA and see if I carry the BRCA gene. Somebody qualified can, after the insurance company or whoever has made a prima facie case that we have unusual data that shows something crazy is going on here. Judge, will you give us an order so that we can look at this? Our experts can, under seal, look at this computer code, protect their intellectual property rights, but we want to see what it says and see if it has that bias baked into it.
Okay. Thank you, Senator Gailey. Senator Blue, do you have a follow-up?
No, I'm good.
Okay. Senator Muhammad, and then Senator Lee, and then Senator Lazara, and we have one more bill. So, Senator Muhammad, please move quickly.
Senator Gailey, quick question. You might have heard about this federal lawsuit against a health insurance company. Question for you, does the bill do anything related to preventing those denials and unnecessary prior authorizations that the health insurers will require? Or are you looking to add something like that?
Senator Gailey?
So there's two things to that. One, the insurance company, the insurance industry is already heavily regulated in its handling claims by the North Carolina Department of Insurance. We already have mechanisms up and running in which are used, I don't know about frequently, but with some regularity to protect the consumers in the health insurance industry. That's number one. And then number two, in the bill, the first page, line 21, an artificial intelligence-based algorithm shall not be used as the sole basis to deny a utilization review determination. So this bill does have a constraint on the health insurance industry that they cannot just summarily deny claims using AI. They have to, if they're going to achieve efficiencies in their own operations, which they can generate from using AI, they're going to have to still go to a human being who's going to be the ultimate decision maker about whether or not something's approved or denied.
Thank you, Senator. So let me keep in order. I'll come back to you, Senator Daniel. May I ask Senator Lee, is your question related to the amendment?
It is not.
Senator Lazar, is your question related to the amendment? Okay, if y'all will hold those, I'll come back to you when we vote the amendment. Senator Daniel, do you want to ask a quick follow-up on that?
No.
Okay, all right. Thank you, sir. Are there any other questions on the amendment? All those in favor of the amendment, please indicate by saying aye. Any opposed? The ayes have it. The bill as amended is back before us. Senator Lee, you're recognized.
I have just a brief comment and then a question. I was not in health. I apologize when this came up. You know, my dad is a physician in a small town, and my mom did all the coding. And it seems like that the benefits of what is provided with AI could be substantial in creating efficiencies. I appreciate the intent of this bill to prevent abuse of that system. You know, when I was growing up, my mom was really proud of the fact that she was really good at coding over the years. And she would maximize the coding, but not upcode, but just find the appropriate code, because finding the appropriate code was not always the easiest thing to do. And so while I appreciate what we're trying to do, I think that whenever we get into kind of AI and algorithms and we start looking at what efficiencies are created and abused, I think we might need to look at it a little bit more holistically, because these efficiencies are benefits that should be benefiting the system and not hurting the system. And I can see where you're going on how this could possibly hurt the system. The second piece of this is really just a J piece, and it talks about in A and B of 413, developers can't do something, and then it says a repeated failure of a developer to comply, irrespective of whether it's being used or not. And I'm not the sharpest knife in the drawer. When Senator Blue said key tam, I had flashbacks to law school. But I think that's something we may need to kind of work through a little bit also. But those are really just my two comments. I appreciate what Senator Gailey's trying to do, but I think we might need to massage a little bit more.
Thank you, Senator Lee. Senator Lazar.
Thank you, Mr. Chairman, and I agree with Senator Lee. I just find that I'm not sure how we audit and verify these denials and the parity and the balance and protection of the citizen. How will these be verified? How do we know that this data isn't being used for denials for profit? What mechanisms would be in place?
Thank you, Senator Lazar. Senator Gailey.
Well, I would just go back to the fact that the insurance company is regulated by the Department of Insurance, and they do vigorously hold the insurance companies accountable. Last year, I think it was United Healthcare got a several $1 million judgment against them because they weren't doing what they were supposed to be doing. And so there are mechanisms in place for the insurance companies. There's not really anything similarly in place for the insurance company. I mean, for the providers.
Senator Sawry, you're recognized.
Thank you, Mr. Chair. And thank you, Co-Chair Gailey, for this important discussion on AI. I want to talk about something Senator Muhammad mentioned a second ago. So the language on the insurance piece, we brought that up. I think it was Senate Bill 316 or 315 to talk about the utilization of AI, utilization review, and prior authorization. And that language came to be as part of our conversations in the long session because of a a company not located in North Carolina was using artificial intelligence-based tools for prior authorization utilization review. And I believe the claim actually in the lawsuit system from it showed that had a 90% error rate and resulted in just awful adverse implications and effects, and maybe even I think there are allegations of deaths as a result of it. And that's terrifying that could go on here in North Carolina. And I don't think we contemplate having this conversation 8-10 years ago about artificial intelligence and healthcare being to the extent that it is today. But I think it's important that we have this discussion holistically on both sides of the equation, both the provider side and the payor side, and that we're having a healthy conversation about it. Just because we're seeing so much money being poured into healthcare, making sure that it's actually being delivered for the benefit of the patient care, because that's the person we're not talking about right now. I think in the context of the discussion is the outcome for the individual, right? It's the providers' upcodes, it's the insurance companies downcoding or denials or something of that nature. But is the patient actually getting that? And I don't know where this piece of legislation is going to go after today necessarily, or if our friends in the other chamber will take a look at it. But I do think it's important that we keep this conversation going, because AI is going to have a substantial disruptive impact on all parts of, I think, the economy and so on, but especially healthcare. And I am concerned about costs to say health plan to Medicaid, and then the outcomes that's going to result to the individual patient. So thank you for the conversation, Senator Galey, on this, and I'm glad that the Judiciary Committee is allowed an opportunity to hear this.
Thank you, Senator. So we do have a motion from Senator Galey for a favorable report to the bill as amended. Before we take that motion, is there anybody in the public that wishes to speak to this bill? I'm not seeing any. So we have a motion before us from Senator Galey, moves for a favorable report to the bill as amended, rolled into a PCS, unfavorable to the original bill with a referral to rules. All those in favor of the motion, please indicate by saying aye. Aye. Any opposed? Ayes have it. Thank you, Senator Galey. The next bill on our agenda is Senate Bill 648. The chair is going to recognize Senator Britt to explain the bill. Members, a little bit unusual. We have this bill back before us for a concurrence vote, but the contents of this bill hadn't been heard in the Senate, and it relates to a J committee. So I hope you've taken a look at it. Senator Britt, you're recognized to explain the bill.
Again, I'm going to run through just from the bill summary, just to highlight the provisions. I'll tell the committee first that this bill did pass the House 114-1. There was work done on this bill with the Ski Areas Association, Advocates for Justice. Senator Newton and I've worked with those individuals throughout the process of getting this bill where it is. The bill first adds definitions for inherent risks of skiing, season pass, ski pass, also amends duties and responsibilities of skiers, permits an assumption of risk as an affirmative defense for a ski care operator, creates Class 1 misdemeanor for misuse of ski pass and unauthorized use of access to a ski area, and hit-and-run collisions, creates a civil action for ski care operator to recover damages from a skier who misuses ski pass or who has access to a ski area without authorization, provides limited immunity for ski area operators or employers or agent related to individuals' detention or arrest for misuse of a ski pass, permitting enforceability of waivers of liability, and exempting bona fide volunteers at the ski area, including youth under the age of 18 for minimum state minimum wage, overtime, youth employment, and record-keeping requirements. Bulk of what this bill does is it protects North Carolina ski industry, tries to keep that a mom-and-pop industry as it is in this state, as opposed to the way it operates in many other states where there are conglomerates that own all of the ski resorts. One example, I think Sugar Mountain, the owner of Sugar Mountain pays $1.5 million a year for what their liability coverage is. So you could just about imagine if you had to pay $1.5 million just for your liability coverage, what that would do to your bottom line. So talking about a $244 million industry here in the state, there's no opposition to this bill that I know of.
Thank you, Senator Britt. Questions from the committee? Interesting. Usually we have a few. We all love skiing, and we love skiing in North Carolina, right, Senator Lazar? I do anyway. That's where I used to work once upon a time, many years ago. Okay, all right. Well, not seeing any questions. Anybody from the public that wishes to speak on this bill? Not seeing anyone. Senator Craven moves to recommend concurrence on Senate Bill 648. With no further comments or questions, all those in favor of that motion to recommend concurrence, all those, please say aye. Aye. Any opposed? The ayes have it, and the bill will be sent forward to the floor. Thank you very much. We are hereby adjourned.